Hi everyone. Today we are privileged to have this interview with Ms. Therese Ramstro. She's a senior occupational therapist at Sahlgrenska University Hospital in Gothenburg, Sweden, and she is also affiliated with the University of Gothenburg Department of Orthopedics. Her clinical focus is upper limb rehabilitation for people with tetraplegia and other CNS injuries, including post-operative rehabilitation after reconstructive hand and spasticity corrective surgery. She has more than 20 years of experience in spinal cord injuries and also completed her doctoral work on rehabilitation and outcome after spasticity correcting surgery in upper limb. Today, we will dig into what OTs see that surgeon might miss and how shared decision making really works and the practical steps that make surgical gains translate into everyday function. Hi, Mistress, and thanks for your time to have this interview with you.
Thank you for inviting me.
It's our pleasure. So we just want to warm up first. If you pull one line to cover this interview, what would you want the surgeon to remember?
I do think one really important thing is the multidisciplinary teamwork and also to really understand the patient's perceived problems and goals with the surgery. And to work in a multidisciplinary team helps with that. So I do
Yeah,
think it's the teamwork I would like to
I can't
highlight.
agree more. Yeah, I can't agree more. So just the first question, I think is quite interesting because surgeons say function and OTs say function. So are we talking about the same thing?
Um, I think in some teams we do actually talk about the same thing when we say function, but we need to be aware that in many cases we actually don't. Often, or in some cases, when surgeons talk about function and occupational therapists talk about function, we might not be referring to the same construct. So even though we use the same word. So for surgeons, many times, and particularly maybe in spasticity management, function is frequently understood more in biomechanical and anatomical. It refers often to maybe outcomes like joint range of motion, muscle balance, reduction of tone. Um, so and when it comes to occupational therapists and rehabilitation in general, function often means more the ability to perform meaningful everyday activities and tasks. So it's more focusing on restoring movement patterns for independence daily living rather than just treating symptoms isolated. So it's more about retraining the body or see the body as a whole system to regain strength, coordination, balance, mobility for real life activities than just the range of motion or tone reduction. So it's about making this movement purposeful and transferable to patients' goals and whatever these goals are. So function from an auto perspective refers more to how a person actually use their body in real life situation. So from an auto perspective, improved range of motion or reduced spasticity is only meaningful if it's actually translating into increased independency or efficacy or safety or satisfaction in daily activities. So I do think that maybe some common misunderstanding could be that sometimes surgeons assume that improved physical capacity automatically improved daily function. But as a OT or in rehabilitation, I mean, this is the crucial rehab part to actually transform these improvements into daily life. So I think this to work with the shared framework where where we have a discussion what function actually means for the the what function means. It's very important because it's not only that it can mean different things for the surgeon and the OT, it also could mean different things for the patient. So yeah.
Yeah, I'm sure there is a common lens for the three of them, but where do you see the mismatch coming from?
I think it could be a lot of this that you maybe take for granted, that in some places you maybe take for granted that improved physical function like this tone reduction, it's actually that means improved function in daily life as well. And it's I think it's not only the word function. It's easy to. It's often that we use different. It's we shorten. It's easy to just say it's function is easy. It's just to say function, and it's some kind of improvement.
Yeah, it's not just a single word. It contains a lot of things on that.
Yeah. So
So
it's just, I mean, and you have the whole ICF framework that's really working on this to have what does actually different. What do we talk about when we say different things? And so it's not just this word. It's not just between OTs and surgeons, and I mean, it's an important thing to have this framework and to be aware that when I say something, the
that
patient might think that I say something else. So
mm,
it's
so
important to be
it's
aware
better.
of that.
Yeah, it's better that the three of them they agreed for what they are looking at.
Yeah.
Yeah. And so for your assessment for the patient and also for the surgeon assessment, uh, do you see something that is crucial that the surgeon must assess before deciding for the surgery?
I think the most crucial thing is to assess to see what are the patient's perceived everyday problems and what are the goals. I think that is the most important thing to before deciding both if spasticity surgery should be performed and how which muscles to target. Um, where I work in my workplace, we primarily use the Canadian Occupation Performance Measure, the COPA, to identify what the patient find most problematic in daily life, and also what they hope to achieve with the treatment. And this provides insight into the patient's perspective, what the problems they have today, but also if the goals are realistic. So to really be aware of that before the surgery, because it's very difficult if we have already performed the surgery and then start to discuss the expectations. So some to really gather the patients, what are the problem for the patients and what do they have, what are the goals with the treatment from the patient's point of view. I think it's really important to have in the assessment toolbox that we need to have when we assess spasticity.
And do you think like uh, I understand definitely for spasticity is quite different from other conditions, and as you mentioned earlier, that teamwork and working with in a team and multidisciplinary team is quite crucial for managing such patients. But do you usually prefer, or like I'm not sure also, like you can share with us about your center. Usually, like how's the patient is evaluated and seen? Like, is it like one room is seen at the same time with the therapist and the surgeon, or like how does it look like?
In where I work, we what we normally do is that when they come for the first assessment, uh, me or either they meet with one of the rehab. It's either me as an occupational therapist or the physiotherapist at the center where I work. So we meet the patient first to see a little bit together, a little bit how do they use the limb today, what are the problems they perceived, and so on. And then we meet together. So I do some assessment, and then I talk to the surgeons, and then we meet together. So we meet a team. So first OT or PT, and then together with the surgeon, and then we can also get a little bit feeling, because there are some patients that they say one thing to
Mm.
me or my PT colleague, and then in the
One
room
decision, yeah.
with the surgeon they say something totally different. So then we can get a feeling about that.
Mm.
Uh, so that is how we do it, and sometimes we at this first meeting we can see that okay, it's this is a patient that we think would benefit from surgery, and then we put them in the program, and then we see them again the day before surgery, and then we do a lot of different assessment, and sometimes it's more like okay, need to discuss, or we want them to try some non-surgery. If they, for example, have not tried Botox yet, we want them to try at least one Botox circle to see, to get expectations, or or if we feel that okay, they don't really have the right expectations here, so we ask them to think a little bit and give them some information, and then we see them again on an outpatient meeting. So for some patients, we see them a couple of times before the surgery to discuss expectations and what and to really get what is the best muscles to target here, and so on. And for some patients, it's kind of enough to just see them at these first outpatient meetings, and we put them up for surgery, and then we see them the day before surgery.
Yeah, I think for spasticity, we are quite privileged to have the Botox because um, it really, as you mentioned, it gives the patient some expectation at what will be after the surgery. So I think it helps also to reduce the disappointment because he can understand what will be next. And if he is not really happy with that, so he doesn't have to proceed with the surgery.
Yeah. Yeah, I do think it's a really good diagnostic tool.
Yeah, and then we will move to patient priorities because I'm sure you handle this a lot. So what do you think like the patient usually wants more? Like is it the hygiene or is it the dressing or he just want to improve his daily activities or he wants some dextry or what do you think he mostly wants?
Most patients that we meet in our team actually says that they want to get function back, and again, what do they mean with that?
Yeah, exactly.
And and most of the patients, when you ask them what do you mean with that, and what is that, they say that they want to start use their hand again. They want some movements back. So um, I do think that a lot of patients that we meet actually have too high expectation of surgery that we cannot realistically always meet. So it's really good to find that out and have that discussion, because um, we meet a lot of patients that has maybe years of Botox treatment and they have no active improvement, either when they have the peak effect of Botox, but still they do think they when we ask about expectation from surgery, they think that, oh, I will get function back, I will get movements back. So it's this is really important to have this again, the multidisciplinary team, so we can gather and understand what the patient actually wants. And when we start to discuss that, then I would say that patients whose primary problems are hygiene and positioning and caregiving burden, they are often very satisfied with the surgery because often we can predict that this will be better. So these goals are quite often achievable. But in contrast, we need to be a bit more cautious with the patient that maybe don't have so much hygiene problem. And they maybe seek surgery more for, they hope to get some active function back, but that is not possible. So I do think a lot of patients that we meet, they think that they will get some function back with surgery. So that is important to really find out and discuss before, because when it is about hygiene and positioning, the outcome is often achievable and it's easier to predict.
Yeah, actually, I can understand where those patients come from because, in general, like even away from spasticity, but in general, people would think that surgery will get them back to normal. Okay, but what is normal? Okay, like is
Yeah.
it your really like state before anything, or like what was? I think they need to understand that this something called the new normal, and going specifically into the spasticity patients, I guess, because they have been in a long journey, and I think also they have tried so many things. So I guess they consider the surgery is their last hope, and I think in that situation they put a lot of expectations on the surgery. So that's where the disappointment comes from.
And in often they think that surgery actually fixes things. You broke your
Mm.
leg and you do surgery and the leg
Mm.
is
Yeah,
it's
exactly.
good again, back to normal, or so I think that is so important to really gather what expectation do the patients have, to have a happy patients afterward.
So moving forward to talk a bit about residual voluntary control. Do you think it is a trend or fall?
Excuse me, can you repeat, please?
Sorry, we are moving to talk about the residual voluntary control. So you
Yeah.
think if the patient having residual voluntary control, this can be a friend or like an enemy to the patient?
Mostly a friend, but
Mm.
I would say, and it's important to see what kind of motor control do they have, what function is, what muscle are still innervated. Um, we do in the clinic where I work, we divide the patient in three different rehabilitation regimen, and they depend a little bit, or they depend on based on the residual muscle function. So if the patient have a lot of residual muscle function, then we can often try to find, and one goal often are to be able to use the spastic arm after the surgery in unilateral daily activities. So then we work towards that. But it's not only the function in the hand, and it's also really important the proximal function. What is the shoulder and scap? Even if, for example, if we have a patient that only have spasticity in the wrist or the fingers, but still have not so much function, residual muscle function in the shoulder, they still will only be able to use the arm as more as a support arm. But if they have good shoulder movement, they could use the arm in unilateral daily activities. So we divide from if the goal is to use in unilateral or more as a support hand, or in the third group where it's mainly hygiene, and the main stratification is the residual muscle function, but then it's also, of course, the cognitive function is also crucial, because the patient needs to be able to understand goals and engage in their rehabilitation, and to integrate the arm in daily activity. If they have decreased the cognitive function, it will be more difficult or a challenge. So then we might need to lower the expectations.
I see. And definitely when we talk about occupational therapists, so we are talking about the kingdom of the splints or poses, positioning, and all this kind of stuff. So what do you think like the most underrated OT tool that would make the surgical outcome last longer?
If we look into like splint, I would say the the most important thing is actually a splint that is tolerated by the patient, because it's not so much about the specific splint design. It's more that the patient need to accept and tolerate the splint, because often, even if after the surgery, they still, most of the patients, especially the patient with that don't have so much residual muscle function, they still need some prolonged stretching, or some, for a lot of patient needs some lifelong splinting, and to actually accept that they need splint needs to be comfortable, they need to be practical, and that is also when it's come to kind of the rehab, the kind of exercises and stretching. I mean, especially if you see after the surgery, you have some kind of window where the patient often are very motivated, and they have actively choose to undergo surgery, and they do rehab afterwards, and then they can undergo some more like range of motion exercises and so on. But I mean, that window are
Right, right.
depends on, it's for some patients it's weeks, for some months, but then you have to find some way to integrate these, if it's exercises or stretching, into more daily life, so it's easy for them to continue to have more long lasting result, even if it's to find when you watch your favorite program, put the arm in this position, or even if it's hard to use the arm just for these and these activities in your life, use the arm and see that as the training session, and then you don't need to do as much of stretching, because you get that when you put the jar in the hand, or whatever. So it's really to try to find this long-lasting solution, and
And
that is often individual for each patient. So
I understand that. So this actually will lead us to the next question, because so Talking about splints or like the post-operative program, um, can you walk us through the first 6 weeks of the post-operative program? Like, what are like the things that are not negotiable by by your side, like either from the surgeon or either from the patient?
So it of course it depends on what kind of procedure is performed. In the center where I work, we do primary tendon lengthening procedures. So one thing that is really crucial is to the edema prevention. Um, so this includes appropriate splints and elevation of the arm and attention to positioning in the beginning. Because poor edema management in the early phase can significantly compromise movement and comfort later and makes the more functional and the range of motion training difficult. In our protocol, we do actually start the rehabilitation the day after the surgery. So we have, for the first 3 weeks, the patient have splints 24/7. So they got a cast during the surgery. The day after, we changed to splint, and we take that splint off 1 to 4 times a day, depending on the patient, and they do range of motion exercises. If they can, they do active. If not, they do passive range of motion. So so and of course it's important to have this in the beginning, to have guided movement, so not to stress the surgical site, but to start to support the motor relearning, because some of the patients actually have residual muscle function that has been kind of hidden behind the spasticity. So that is our protocol the first 3 weeks. It's splint 24/7, take the splint off and do range of motion exercises, active or passive, and really work with the edema control to prevent edema. And then I would say also what is important in the beginning is to focus, but this is more maybe, so after 3 weeks in our protocol, they use the splint night times after that. So during daytime, they can start to use the hand in more lighter activities. But that is to focus on actually activating and strengthening the antagonist to the lengthened muscle. Because, for example, if the finger flexors are lengthened and the patient have actually used the spasticity to put things in the ham, they can be quite stressed in the beginning because they feel that they have lost something, and they start to work with flexion of the hand before they have had the possibility to strengthen the extensors. So it's really important to prioritize strengthening the antagonist muscles and inform and patient, but we always inform this before the surgery, that and to so they don't stress too much about what they have lost in the beginning. So I think that is a common mistake, is to focusing too much what have been lost in the short term, rather than building new functional movement. And again, it's also important, this you know, like we talked about before, this, like the rehabilitation window. I mean, the first 6 weeks, the patient are often quite motivated to do range of motion exercises and so on, and then it's important to see how can we work further with that to transform this exercise into more daily everyday life activities, because they will not, most of the patient will not be motivated to do range of motion exercises for the rest of their life. So it's to early start to think how to transform this.
So we move to our next question. So previously you mentioned that function is not about only the range of motion, and there is other things that can be translated into function. So after the surgery, how do you deal with the patient function point of view?
Um, you mean more like training the function,
Yeah, I
or
mean,
to
because like
to
the
move
surgery already
into.
done. Yeah, the surgery already done, and then you have your protocol post-surgery. So what the patient, like we mentioned that some patients are looking into the hygiene, some patients looking into like other stuff like the dressing and stuff. But how do you deal with all that?
So we used the Canadian Occupational Performance Measure before surgeries. We gather before the surgery. We talk about the goals, and we use the COPM for that, and therefore we have. And we do that both to actually see that the patient, both to learn what kind of problems do the patient perceive, but also to see if they are kind of have the right expectation. And the main thing for us to is also to use these prioritized activities in the training afterwards. So depending on the goals, we tailor the rehabilitation towards that. So if it's mainly hygiene, because that is what the expectation and what the possibilities are, uh, then we work. Then it's more about range, and often because they don't have active muscle function, it's more passive range of motion, and that is what we can work with, and maybe sitting position, and find out how, try to see where to have this prolonged stretching. How can you position your arm in different situation during the day, and then if we have patients where the goal is more to have the arm in as a support arm, and they have certain activities they want to achieve, then we tailor both what kind of muscles we work with and range of motion towards this, and then we work with the activities. So we tailor the rehabilitation after the goals, and the goals are of course tailored what could be
Mm.
expected. So we individualize the rehabilitation depending on the possibilities and the goals.
And this
So
is
it's both a lot of range of motion exercises, of course, and training the muscles, and then transfer this into to activities in daily life.
and this is also like modifiable or adjustable along the track, or usually the plan is already prepared and you just follow the plan all the way.
We do the plan before the surgery, but sometimes, of course, we think that the patient have more residual muscle function behind the spasticity than they have, and then we have to re-evaluate and do a new plan, and uh, and sometimes they have more residual muscle function than we anticipated, and then we can also evaluate. So of course we need to adjust along the process, but we do have a plan before the surgery.
And you think, because some of the surgeons we had interviews with them about the spasticity, they said taking videos is usually is a good tool at different stages of the patient management because sometimes when the patient reach the plateau phase or sometimes like they get disappointed because they haven't met what they are looking for. So these use those videos to refresh the patient to tell him like see what we have been at and what we are now. So you think also like taking videos or do you do this in your practice?
Yes, we do, and it's really good as you point this out. It's so important. It's so important, especially for the patient, because sometimes they, when we meet them, maybe. So we normally meet them for a follow up 3, 6, and 12 months after the surgery, and sometimes they like, oh, it's like before,
Mm,
and when you look at the video, like, no, it's really not like before. So it really helps the patient too. And some of them are like, what? Is that my hand? Was this how it was before? Yeah, it was. But it also helps me because I don't always remember either. Like,
mm,
how was this hand before? And oh, is this really good? And so it helps the patient definitely, and it's so good. But it also helps me as a therapist to help me remember as well. So I really recommend that. So we do normally we do videos both on like the what kind of range of motion they have, both passive and active. But we also, because again we use the COPM, so the activity goals that they have, we do videos on them as well. So if it's about picking up a glass, we ask them to pick up the glass and we record that, so then we can also they can also see both the range of motion, but also how they use their hand or arm in activities.
uh, Going back to talk about the multidisciplinary team, so we would like to hear from you like a story about one patient where like the multidisciplinary team become like a surprising win and the patient was very happy with the outcome.
Um, I think again the important thing is this that we have seen is some patients where, like we talked about before, they say one thing to me as an OT and another thing to the surgeon. So we have had some situations where this really have helped us when the patient has said one thing to me, and then they have said another thing to the surgeons. And because we have this multidisciplinary team, we have discussed it in the team, and then we have had meeting with the patient again, so we really could have been able to target the misunderstanding and the mismatch, or so for example, we had one patient that when he talked to me and my PT colleague, we felt that okay, the expectations are really too high here. And when he talked to the surgeon, he was just so keen on getting the surgery. So it's like,
Mm,
no, I'm totally on board with what you are saying. Like, okay, it's not the same. So then it was really important to have first the multidisciplinary team discussion, and then the discussion with the patient, then to really put down and understand, okay, so here is a patient that we need to, like I talked about before, some patient we kind of only need to meet at one outpatient meeting, but this we need to see him a couple of times before we do the surgery, so he's really on board and have the right expectation. And I think that if we didn't have this close collaboration, we might have missed this, because the patient was uh,
and
really good at saying to the surgeons that no, I totally understand, and I do understand that this is the only thing that I will gain. So we have a couple of these kind of patients where we really have said in the team after it's so good that we have this multidisciplinary team so we can pick up this thing.
Okay. And do you have like the other side where like the outcome was totally disappointed?
Yeah, we do have, of course. I mean, it's both where I know we have, for example, one patient where we might not have been so the expectation were not aligned what we as the team and the patient. So we so he I mean, from our point of view, the treatment was met the expectation, but not for him. So he seeks us regularly and ask about. He wants to do more surgery and more surgery and more surgery to try because he really think that he can get kind of a normal hand after the surgery, and it's it's hard when you have started doing surgery to because you have kind of opened the box for the patient and now but no you have done this and I think if we just do a little bit more of this and that or that then it will be better. Then sometimes it's easier to say no from the beginning. Your expectations are not what we can live up to, so we cannot offer this treatment. But when you have done surgery, you do have a responsibility for the patient afterwards, and so it's again so important that expectations are aligned before, because it's really hard afterwards.
Yeah,
When
there is no
but you
undo button for
told
that.
me and you yeah. So we do have some patients where we can see afterwards that okay, we might thought that we were clear, but obviously not. And then we always have the patients that it doesn't matter how clear we are, and they can have written information about expectation, and they still will not be happy with it. But then we can at least say that, but sure, look, this is what we agree about.
I see.
So, but
And like those kind of patients, by your practice, did you find like any red flags or any criteria that you would try to identify such patients from the start so it doesn't go wrong again?
yeah, I think it's therefore again a little bit this when they have unrealistic expectation, uh, that it's really red flag, and even some of them are like, oh, but you can always hope. No, we need to be realistic. So it's both when they have unrealistic expectation, but also when they have maybe limited engagement in both goal setting and when how it if they have lack of motivation or support for the post-operative rehabilitation. It's also maybe not red flags that they are not going to do they are not suitable for surgery, but that we really need to be sure that they know what to expect, because we also have because some of the patients don't have the support. So during the post-operative rehabilitation, when they have the arm in a splint, for example, if they walk with a walker, they can't. They need to make sure that we need to make sure that they will actually manage after the surgery with the post-operative restrictions, and also so that they are able to do because in our protocol they do a lot of we guide them, but a lot of the rehabilitation they actually need to do by themselves, and they need to be motivated for that, especially if the aim is to be able to use the hand. I mean, if it's more the hygiene aspect, then it's a little bit another thing. Then we don't need to have. They don't need to be that much. They don't need the same. They don't do the same rehabilitation. But it's mainly the unrealistic expectation. It's the really, really red flag that we need to target them and work with before the surgery, because we will not be able to do it afterwards. Because
And this actually was our last question, and we just want to wrap up this interesting interview uh, and ask you about if you have any myth about this spasticity that you wish it could retire.
say that once more. Any?
If you have any myth about spasticity and you wish that this is to retire, that people no longer believe in that.
I do hope. I mean, for you I mean, you see and you can read a lot that a lot of people, especially in the rehab field, think that this surgery for spasticity is kind of the last
Last
option,
hope, yeah,
and
last option, yeah.
yeah, and only for kind of the really severe cases where the aim is hygiene and so on. But I do think that it's would be a really good if the surgery option were more integrated earlier, and to have this multidisciplinary team, both this multidisciplinary surgery team with the good collaboration with the rehab doctor team, would really benefit for the patients, because the spasticity. I'm working with stroke and TBE patients, but mainly also mainly a lot with the spinal cord patient, and I mean, spasticity becomes more and more common with the incomplete patients. So it's a field that is important, and it hinder the patients so much. So I hopefully it will be more common with that surgery will be an option for more patients, and especially in a multidisciplinary team. That is what I hope for when it comes to spasticity.
Well said. Because our last interview with Dr. Caroline Leclerc, she almost said the same also. Like she always said she wished that the patient or like either the therapist or like the physicians, they can refer the patient earlier so they can have better outcome. Because sometimes, as you mentioned, like people say, okay, you have tried everything, so let's go and see what surgery can do for you. But it is too late to try the surgery.
Yeah, often it is when you have contractures and so on. But I also think that to get there, it's important that the surgery team really, we need to be aware which patient to actually do surgery on, because and this with the expectations and so on, because if we have a lot of patients that don't meet the goals with the surgery, then it will be harder to kind
So,
of recruit
mm,
and expand the
mm.
service. But I hope it will be not seen as a last option.
Yeah, we all hope so. And I think this also all alludes to what you mentioned in the beginning, that multidisciplinary team is the most crucial for managing such patients.
Yeah, I do. I really think, and I do think so. So that is to get better outcomes and more patients that will benefit.
Yeah, sure. Thank you so much for your time. And this really was a quite interesting interview. And it is good to understand like other side interview so we can all share the common lens to achieve the patient outcome. And we do our best to try to meet his expectations, even if it's sometimes it's quite high, but we all work for that.
Yeah. Thank you very
Thank
much.
you. Thank you. Have a good day.
Thank you.
Thank you. Bye bye.
Same to you. Thank you. Bye.